Paul is a consultant ophthalmologist and Director of Education at Moorfields Eye Hospital. He's authored nearly 50 papers in peer-reviewed journals and is a very well-renowned speaker and has spoken at conferences all around the world. Before I actually ask Paul to start, sorry, I was asked to say that the heating has now been put on for all of those of you, including myself, that were feeling a bit chilly. So you should warm up very shortly. So please, would you give Paul a welcome before he starts his presentation on flashes and flows.
Thank you very much. Thank you very much for inviting me on this lovely day down to this lovely city. The title of my presentation is The Optometrist's Role in Prevention of Blindness from Retinal Detachment. And I think that's, given the title of your Congress, Optometry Tomorrow, it's actually a cracking title because it's kind of forward-looking. If we take this patient, it's quite clear what my role here is, which is this is somebody with a retina superior, there's a tear at the top there. And actually, some of you are looking at that one, so I'll try and avoid using a laser. But you can see there's a superior retinal tear and an extensive retinal detachment that's involved the macula. And we're fairly good, retinal surgeons like myself, at fixing these. But what we can't do, of course, is recover all the vision that's lost once the macula is detached. And it seems to me that the title acknowledges your role here, which seems to be one that has changed over my sort of 30-odd years of doing ophthalmology, to one that really respects your training and professionalism much more than the situation was in 1988 when I started off in eyes. Another thing I'd like to mention is that I do have some awareness of optometrists' abilities to work in this area, because Graham McAllister, who, as far as I know, is the only optometrist working in an advanced practitioner role in this area of vitreoretinal surgery, works alongside me in my clinic at Moorfields, seeing and assessing patients with advanced and complex vitreoretinal pathology. What is your role here in getting this patient to me as quickly as possible? Is it all about screening patients with sort of optomaps and screening peripheral fundi before problems arise? Is it to do with the way you manage and assess patients? Is it, as I think perhaps it would have been the view in the past, a question of simply sending everyone up, not being able to make any treatment decisions? And here there's a dilemma for me, because I have to decide whether I'm here to train you or educate you. If I'm here to train you, I can probably answer that question in about 2 sentences. We can all go for coffee. But if I'm going to educate you, I actually have to slightly reprogram you, change the way you think. And for that, we have to go on a little journey and let the answers sort of come out naturally during the discourse. So, to start at the beginning, floaters. You see a lot of them, and you're all aware that they're an area of risk for the patient and for you, as an area of potential litigation. What is a floater? How do we find them? Well, for a good description of a floater, you can't get better than King of the Hill. Now, I hope the sound comes on here. Do we have sound? Let's see. Oh, it appears not. Okay.
Longer, you're going to feel smaller than my eye floaters. Here's one now. I can never look at it dead on. It's always trying to get away. Hey, eye floater. Hi. Hey, where you going? Away from your pupil. Well, maybe I'll look over here. I'll go over here. You got an answer for everything, don't you?
And that is the characteristic of a floater, isn't it? They float. They overshoot and then drift back, and you can flick them in and out of your vision. There's not much of a differential diagnosis, but it's worth establishing they're not affected by blinking, because patients do, of course, sometimes see, patients with tear film problems do sometimes see junk floating around in their tear film. That's one potential area for confusion. It's quite interesting, if you look at the history, the ancient Greeks had a term for seeing floaters. It's myodysopsia. And the opsia thing, that sort of, we all know from opsins and things, that means vision. The myodes is a figure from Greek mythology who was cursed with such an appetite that he had to eat constantly. And the Greeks associated the flies that appeared on their sacrifices with him. And so because of this close association with flies and the appearance of floaters like flies, that's where that term comes from. And the association with flies is something that we also see in the French and the Latin terms. So floaters have been with us for a long time. But not everyone describes them as these little specks that float around. I mean, not everyone comes in and says, I have a floater. There's all sorts of weird ways they describe them, particularly if they have a vitreous detachment. They sometimes have a slightly different sort of visual disturbance. It's like a blanket or a film that drifts across the vision. And this is because the posterior hyaloid. When we think about the vitreous, we think about something that's very homogeneous. But when you operate on it, you realize that vitreous isn't actually like that. It's rather like Australia. It's pretty empty in the middle and all the interesting bits around the edge. And the hyaloid membrane, which is the edge bit, is just slightly, I won't say opaque, but translucent, should we say, rather than transparent. So when it detaches, you do get this sort of billowing sheet effect. And some patients find it very difficult to articulate what they're seeing. Which is why sometimes, when you've got somebody walking in with acute visual disturbance, you may find it difficult to work out whether they're really describing, floaters, vitreous detachment or not. The focus in the first part of this talk is going to be on, the degeneration of the vitreous and the types of vitreous opacities that are relevant to tears and prevention of retinal detachment. But I'm going to talk about the others as well, because there are some interesting things that we can think about how we manage these patients. We've known a lot about, a bit about the structure of the vitreous for a very long time. This is the scene from King Lear, where Cornwall enucleates Gloucester bilaterally, shouting, "Out vile jelly." So even then, when there was limited understanding of ocular physiology, they knew that the eye was full of a jelly substance, which is still the term that we pretty much use for it. What do we mean when we say vitreous is a gel? My son said, "What does that mean, Dad?" He looked over my shoulder. "What does that mean, mostly liquid with the structural coherence of solid?" The best way I could explain it is, well, it means it wobbles on a plate, which is like a jelly. The reason it does this is because of the distribution of solid and liquid elements within it, the even distribution. Hence the similarity with food. So this is the vitreous of a young child. If you hung it up to dry and came back several weeks later, one time all the water had, gone, you'd end up with something looking a bit like a human hair, just to illustrate how much of that volume is water trapped within the tertiary structure of the vitreous. It's actually 98%, only 2% solids. And the solids have this sort of fibrillar structure on microscopy. And there's two main substances, two main solids, the yellow bars, which are the collagen, and the green little globules, which are something called hyaluronic acid. So every ground substance in the body is made of these two. The collagen gives the vitreous a degree of strength, and the hyaluronic acid has an affinity for water and sort of inflates it and spreads it out. So it's an interesting sort of relationship between them. So that's a gel. And one thing that most gels will do in time is degenerate. They're inherently a little bit unstable. So that's the solid and the liquid, and in time they separate out. And this is called into two phases, a solid phase and a liquid phase. This is the process happening in a laboratory. That's a gel that's just been left in a tube for a year. And you can see that it's moved into solid and separate solid and liquid phases. Now, we could have taken choosing a name for this process, I think it says a lot about the psychology of eye care specialists. We could have taken terms from chemical engineering, from some other area, but we chose one from food technology. This is syneresis, is the degeneration of food gels. So this is syneresis of custard. And that's the term. From every other area where gels are used, we took one from food. As I say, I think that says something about us. And then, once you understand this, you can understand vitreous detachment as being a sort of a culmination of this process, where you get these fluid-filled cavities and strands, visible strands appearing in the vitreous, where usually at the posteriorly, you get a hole in this structure, the posterior hyaloid. Do you remember I said the vitreous wasn't completely homogeneous? It's got this like sheet at the back, which is what it really is, the posterior hyaloid. So the sequence of events is the gel degenerates, changes colour, and then collapses away from the retina. Why exactly does this happen? Apart from, well, we've already said that you could look at it the other way around. You could say that alone in gels in nature, this is one that keeps its gel structure for 20, 30 years. It's amazing it can even keep it that long. And you might add that the human body was probably only sort of, well, I won't say designed, but that we essentially, that's the time which degenerative processes tend to kick in. But it does happen much earlier in myopic patients. But the thing I want to stress, and this is important for considering other diseases in the eye, is that the vitreous is a house of cards. And when I say that, the characteristic of a house of cards is that if you just take away one little card at the bottom, everything falls apart. Any slight change in the chemical composition of the vitreous, therefore, will cause vitreous degeneration and vitreous detachment. So if any of you are having to swap this sort of stuff up for exams, any condition causing blood retinal barrier leakage, trauma, inflammation in the eye, by changing that very subtle balance of solid and liquid chemical structures, will cause ultimately a vitreous detachment. And the consequences, well, the consequence is traction. As the vitreous moves around inside the eye, it tugs on the peripheral retina. And I'm making this point slightly out of sequence, but I think it's worth underlining. When I was much younger and people had a detached retina from vitreous traction, I used to advise them against doing sport for a period afterwards, on the grounds that the movement of the eye and the associated vitreous might produce ongoing traction and problems, until one of them, who was an ocular neurophysiologist, pointed out that by this logic he should also avoid sleeping, because of course that's when our eyes are move most quickly. So it's a bit of an aside, but there is really no reason anymore, or there never was really a very good reason, for getting our patients who've had vitreous problems to change their daily living activities. Because if we were going to ask them to stop doing anything, it should be sleeping. Anyway, that's an aside. The consequences of posterior vitreous detachment are seen, of course, at the vitreous base. The vitreous base is the area beyond which a posterior vitreous detachment can't extend, because the vitreous is inserted into the cytoskeleton of the retina. That's as far as a PVD can go. That's the way to think about the vitreous base. So let's think about how retinal tears happen. And I want to basically, I want you to imagine that this is something called a Miyake view. So you're sitting on the optic nerve looking forward, all right? And you're looking at the lens from the back. And what you're going to see is what happens when you have a PVD sitting from the back. And you get, hopefully this will come across in the animation, I don't know if you can just about see that circle. Do you see it goes in an annular configuration? Now, what I want to do is to consider another scenario. In that situation, the circle came in equally all the way round. But I want you to consider, watch this. If you look on the right-hand side, it doesn't detach as far forward. Did you see that? So the vitreous base extends a little bit backwards. Now, what does this mean? When we actually start to look around, and the vitreous is sloshing around in the eye, tugging on the peripheral retina, what's the implication of that? Well, it's enormous. In the first situation, where the vitreous base is roughly and circular, the forces that are generated by the eye movement are symmetrically distributed. But in the second situation, they're concentrated on that area where the vitreous base hasn't been able to detach as far forward. And this is something that's been shown, theoretically. So what sort of conditions make the vitreous base not detach as anteriorly like that? And it's a condition you've all heard of. It's lattice degeneration. And my real point is that this is the way we should think about lattice. We shouldn't think about what it looks like, what colour it is. I mean, so the definition in your books is circumferentially orientated areas of sclerosed vessels and pigmentation in the pre-equatorial region. That's very, very boring. What's really interesting about it is the vitreous is so stuck down that it can't detach through the lattice. And you can see that on that on the right-hand side, you have electron microscope graph, and you can see there's some atrophic holes in the center of the lattice, but also you can see a ridge around the edge, and that's where the vitreous is stuck down around the edge of the lattice. Which means that when the vitreous, so what I'm saying in essence is that when you have a posterior vitreous detachment, you tear around the lattice. That's shown on that animation, and here you can see that very clearly in this picture from Kansky. The tear is the lattice, in fact. We can actually see the posterior hyaloid in relation with tears. In a detached retina, you can often see the posterior hyaloid as a little white line. Can you see that? Joining up the tears. It's irregular, moving backwards and forwards, and all the tears will be on that line. So how do we diagnose a posterior vid detachment clinically? Well, I'm sure you all know about vice rings, and there is a vice ring on this video at the top. Now, it's not just in front of the nerve. Because the vitreous has collapsed forward, it's actually above its superior, and it's not really in a ring shape, because it's sort of collapsed along with the rest of the vitreous. And I'm sure this is something you've all seen. But there's a much more reliable way of diagnosing vitreous PVD when there's a lot of collapse. And that is to get the patient to look up. You don't use any lens. There's no 90D lens here. You ask the patient to look up, and you use a cross-set slit beam. An offset slit beam, about 15 degrees, very narrow, very bright. And this is what you see in an eye with a posterior vitreous detachment. You see a crinkly membrane. Now, the important property here is not the appearance that it's dark behind, because the vitreous often has folds. So you might see another apparent layer behind it. The important property there reflects the fact the posterior hyaloid, remember that structure we were talking about earlier, is inelastic. That's why you get tears. If it was elastic, it bent, it wouldn't pull on the retina. It's inelastic. Because it's inelastic, when it collapses, you get redundancy folds, like a sheet that you sort of half drop, Let's compare that with an eye with syneresis. You can see strands of collagen, and you can see what look like black spaces. But there isn't that same continuous sheet. It's the crinkly membrane that tells you there's a posterior vitreous detachment. Let's just review those videos side by side. So on the left, a PVD, the crinkly membrane. You often have to, the other thing to say about this is, you often have to get the patient to look up, and then they have to keep looking up for about 10, 20 seconds, because the vitreous has to collapse a little bit, has to settle. So if you don't see it initially, keep looking. And of course, as you understand, these are important because there may be tears, and it's your job to find these for me and send the patients to me, ideally before the macula detaches or even before the retina detaches. And you're all familiar with the appearance of retinal detachment. Just one little thing. If you're not sure, if you're looking at and you can't quite decide, is the retina detached or not, this picture does show one little thing you can look for if there's a shallow detachment, which is the loss of choroidal markings. Maybe you all know this, but if you look there, you can see the choroidal vessels, these tigroid stripes. When you have even quite shallow fluid, those disappear. And that's a useful little sign if you're just not sure. But obviously, ideally, we'd like to catch things before they get to that stage. We want to catch it when it's just a tear. And the way I was taught when I was training, and I'm sure you were as well, was that we need to indent. And this was particularly important, of course, in the age, most of you are much younger than me, but those of you who are older will remember that we're learning and trying to see the peripheral retina with a direct ophthalmoscope and how challenging that was. But actually, now that we have very wide field indirect lenses, you know, the sort of the superfields, etc., all those sort of amazing biomicroscopic slit lamp lenses, we can see far further out than we ever used to with the direct ophthalmoscope. And in practice, we don't need to indent anymore to see tears, because the point is, and none of these lenses will allow you to see the ora serrata. That's true. But retinal tears don't happen at the ora serrata. There is a type of retinal break that does, called a retinal dialysis, but I think that it's they don't present with flashes and floaters. They walk in with a black eye saying they've been hit in the eye. And that there you do need to indent. There they can get very anterior breaks at the ora serrata. But the person who walks in to your consulting room with flashes and floaters will not have a break at the ora serrata. It will be at the posterior border of the vitreous base, which is just anterior to the equator, which you can see with slit lamp biomicroscopy. So a few tips for seeing the peripheral retina. Obviously get the pupil as well dilated as possible, and a superfield lens. But here's another one that some people aren't aware of. On the left, you've got, these are the same eye, but a wider field. And we've achieved that wider field by moving the lens very slightly close to the cornea. So the closer you can get the lens to the cornea, short of actually getting your valuable lens covered with meibomian grease from the patient's lashes, the further out you see. Referral. Well, with retinal detachment and retinal tear, it's easy. They're the same day. I mean, I'm being a big dogmatic here. If somebody's clearly you've got a very chronic retinal detachment that's been there for years, then use your professional judgment and common sense, which you all have. But in general, somebody with an acute presentation needs to be at least referred the same day. If somebody else decides not to see them the same day, then that's their problem. But I want to highlight something else. Vitreous hemorrhage is just the same. If you've got a vitreous hemorrhage in a patient who is not a diabetic, that is a retinal tear until proved otherwise, and many of them actually are. And here's why. Because if you look at that picture, you can see there are retinal vessels going through that tear that can actually, so hemorrhage can be a very early presentation of a tear. And this is not rare. This is common. I mean, if you take 100 patients with vitreous hemorrhage of unknown origin, a good 30 or 40 of them will have retinal tears. So it's not something that's really, really unusual within that group. But supposing you don't find anything, what do you do then? And here I believe, your college guidelines have changed quite appropriately. Assuming you feel competent, and that is an assumption, and I appreciate not everyone will, but assuming you feel competent that you've had a good view of the peripheral retina, you can discharge them. I think you should document, and this is where protecting yourself comes in, you should document that you've had a good look, that you've had a good view, cooperative patient, and that you've given the patient a retinal detachment warning to come back if things change. Those are the things that will protect you in the event of the patient subsequently getting a detached retina. Because they could. A proportion of patients will get tears, a very small proportion will get tears subsequently, whether I see them or you see them. If I see them discharged, and it's still the same situation. What should you say in your retinal detachment warning? And this is a difficult one. I think you should focus more on the scotoma than the flashing lights. Because just imagine your vitreous is detached and you've got a tear. Okay? And you've got the floaters. Okay? Now, what are you going to see? When the retina detaches, you're not going to, or even say you see somebody at the PVD before they have a tear. So they've got floaters, right? Then you send them away, and then a week later the retina tears, as can happen. What change in symptomatology will they see? Will they see additional floaters? Well, only if they get a mass of them from a tear through a vessel. But generally, the new symptom that people see is a scotoma. So that's the thing we really need to focus on. More than the flashing lights, more than a change in flashing lights, more than a change in floaters. Do you need to review them? The actual instance is very, very low. And the problem with regular review is, I mean, how often do you review them and what for? The way I sometimes explain to patients is that somebody, if your house has burnt down and you're worried that it might burn down again, how often do you call the fire brigade out to check? Once a month, is that enough? Once a week? And that's the problem. When you have symptoms, you need to be seen very, very quickly. So I think we should divert our resources more towards seeing people who have a problem very quickly and trying to get rid of long waiting lists rather than bringing everyone back. That's just my personal opinion. I'd like to also just remember, because I'm interested in the whole patient with floaters, a few other conditions. Let's just have a case history. Let's see if you can make a diagnosis here. This girl's 30, and she's not myopic. She's young to have floaters, isn't she? And she's had them for 2 weeks. Okay, so have a look. And she's got a vice ring, but she's got something else. What's that? Anyone? Good, yeah, absolutely. Toxoplasma choroiditis. And actually, there is a real lesson here, because we could have made that diagnosis a little bit earlier by looking in her anterior segment. People with floaters, people with PVDs don't get KPs. And I always look in there. This is something I've seen on several occasions. So always look at the anterior segment in these young, annoying patients with troublesome floaters. Always look in the anterior segment. Okay, what should we do about the patient? I mean, we may think we're reassuring them when we tell them this, but from the patient's point of view, that can come across as very, very unsympathetic. Let's consider another case history. He's a taxi driver with troublesome floaters. And so there's no doubt that some patients find these very, very annoying and say that they do interfere with driving and daily living activities. And we've always said, well, because it's normal, vitrectomy is not justified. You know, this patient, what, 6'9", 6'12"? There's a 6'9" diabetic with recurrent vitreous hemorrhage. We're quite happy to operate on him. This was somebody with, I believe that was actually post-toxicara, and that was a Fuchs heterochromtic cyclitis. They're all 6'9", but we're all quite happy to operate on them because they've got pathology in the eye. Whereas the person who can't drive and be a taxi driver, because he's got a normal eye, at the same level of acuity and probable function disturbance of everyday life, we tell him to live with it. What's against operating? Well, it's this, really. It's the worry that when we're doing our detached retina, when we're doing the vitrectomy, we'll actually make a little tear in the retina there that could lead to a detached retina. And that's what's led to the search for other solutions, like this, laser treatment, highly advertised on the internet. Here, this is a video courtesy of Scott Geller, who does this treatment in the States. You can kind of see the problem you might run into just from what's happening there. You're taking one floater of a certain size and dividing into two, each of half the size. And you can go on and on and on, but it doesn't get rid of the stuff, which is actually what annoys the patients. And when this has been looked at systematically, the only sort of systematic study I'm aware of that was really objective in the UK, really found it beneficial in some benefit, not a lot, some benefit in a third of cases, because it breaks them up rather than removes them. Can it have complications? Well, not if you believe the people, their advocates, who do nothing else, by the way. There's a few people who do nothing else. Not a single case report in the literature, according to Dr. Karikoff on the Eye Floaters website. Well, he ought to learn to use Google better, frankly, because it didn't take me very long to find this case who had the posterior capsule blown out. I want to move on. So that's the symptomatic PVD group. And my bottom line is there, in extremis, I mean, I'm not saying we want to do this on everyone, but there are some people who are really disabled by these, and we should be more, when I say we, I don't mean you, I mean, as ophthalmologists, we should, I think, be more sympathetic to them. I want to move on to syneresis, which is slightly more difficult. These are the young patients who don't have PVDs. They've just got what we would regard as I mean, we probably all have floaters ourselves. I can certainly see mine. They don't trouble me that much. But some people, it really does bother them. And something that I'm sure we've all noticed with these is that you often look in and you don't really see very much. If you go on to FloaterNet or FloaterWeb, you can find some. I'll give you a minute to digest this, and the next couple of slides, which come from FloaterNet. These people have some pretty strange ideas about what's going on in their eye. They compare notes, and they're clearly very, very, very anxious. Can you read that? This is somebody who thinks he's going to die. He thinks that somehow the floaters mean he's going to die. They put up pictures of their floaters to compare them, how bad they are. You've got advice on how to draw your own floaters and post them on the internet. And sometimes the results are very revealing. If there were general practitioners here, they wouldn't be surprised by any of this. There's a condition called somatization, which is basically psychological distress is manifested physically. Probably something we've often seen, in people. It's really common. It may be something you've seen, even outside work, friends and relatives when they're having a difficult time. I still think that we shouldn't be unsympathetic to these patients, because it does just drive them into the hands of the unconventional practitioners. Again, people like Natural Eye Care, who have you got patients on these floater caps or floater pellets? If you look at the ingredients, it's interesting actually. It's phosphorus, which I guess is one. I can imagine phosphorus would get rid of your floaters. Fortunately, it's a homeopathic remedy. So when I say it contains apologies to any homeopaths, sorry, but when I say it contains phosphorus, there's a degree of terminological inexactitude there. So I still think that these patients need to be reassured. I think we need to try and address their fears, and they're often along the lines of, a year ago I didn't see these, now I did see them. And then they extrapolate. They say, I've gone from 0 to this in 1 year, in 5 years I won't be able to work. This is the kind of, and I say, no, that's not how it works. That's not how perception works. And I'll do an experiment on you all now to show how it really works. Right, until this second, in a second I'm going to make you all aware of something, and I'm going to click my fingers, and then I'm going to make you aware of something that you weren't aware of before. You're all wearing shoes. A minute ago you couldn't feel them. But now you're all aware of them. Concentrate on them for a bit. Just feel them. Feel them on your feet. You can actually get quite sort of... The point is that those touch receptors in your feet have been firing signals up your spinal cord to your brain, and it's got a junk mail filter on your attention. Your cortex is saying, no, I don't want to know. Stop telling me about my shit. I can feel them now. They're getting quite irritating, actually. But actually what happens is, the way the brain works is that instead of putting a junk mail filter on that information from your feet, you can put a priority alert so that you get really, really aware of it. And that's what's happened to a lot of these patients. And that's why we've got to... the trouble is, if we're unsympathetic, or the worst thing you can do, of course, if it's a young patient with floaters and no PVD, the worst thing you can do is give them a retinal detachment warning. Because what that's doing is putting it's going to make it much more difficult to ignore. How about vitrectomy in this group? I mean, they are a group that, when we do a vitrectomy, we have to peel the vitreous off the retina, and it's often. This was a young patient with floaters I did a vitrectomy on, and had torn the retina. I mean, he did fine in the end, but it's not straightforward. It is more risky than just doing a vitrectomy in an elderly patient with troublesome floaters. There are various, and patients know these terms. That's why I'm coming up with them. Well, you just take out the bits. Just take out the bits that are floating around. The problem is, you do this, and they become aware of other bits. So it does seem that I'll skip that. It does seem that just removing the bits that you can see isn't quite enough for these groups. Coping strategies. Well, I think coping strategies are actually all about talking to people. We refer people to counselling. We should be doing the counselling ourselves. We should be telling them some of the things I told you, if it's, the young syneretic group. Explain, they need to know the nature of these things. Tell them they haven't got a PVD, because of course they've been on the internet. They all think they've got retinal tears. So explain that things are likely not to progress. I do actually also say, at the end of the day, if you're really distressed at a certain period from now, I will do a vitrectomy on you. I am prepared to do it. And the reason, and I've hardly ever had them take me up on it. Just having that conversation with them And the feeling that somebody recognised what they're going through so it means that the anxiety over the situation gets less, which means that, of course, they perceive them troublesome less. So just saying you'll never do a vitrectomy isn't helpful. It is important to point out the risks of the procedure, of course. And that needs to be a balanced risk. A very high likelihood of cataract. The risk of retinal detachment is very, very small, 1 in 100. I have caused a retinal detachment doing a floaterectomy. He did fine with the second operation. The interesting thing is, and I've operated on ones that have had retinal detachments after other people have had floaterectomy, so I've experienced a few that have had this worst of all complications, and they've still been very happy. I mean, they still say that having their floaters removed was the best thing they ever did. So I'm not promoting it. I'm just simply pointing out that our discussion of risks has to be balanced. 1 in 1,000 endophthalmitis, that's really much more of a worry. But I still, my own approach is never to say never. Okay, I want to say a word. I've spent a long time talking about floaters. I have to say a little bit about flashing lights. So they can arise from the retina or the cerebral cortex. PVD photopsia, of course, they've got associated floaters, but there are 1 or 2 other things that tell you this is definitely a PVD. They're all down the temporal side. That's got no localization value where you see the flashing lights. It's always down the temporal side, wherever the PVD has started. They're more apparent in the dark, and they may be provoked by ocular movement. I shall leave that, I think. Unlike classical migraine, where you've got this history of 2 phases. You've got the spasm phase of migraine, where the blood vessels go into spasm, and that usually lasts about half an hour, and you get a neurological deficit of some sort, or flashing lights. But it can be, it can be a hemiparesis. It can be an ability to move an arm or something, because the vessel's going into spasm. And then this reactive phase, when the vessel that's gone into spasm massively dilates and stretches all the meninges, and you get this 24-hour headache and vomiting. But don't forget, older patients, where the blood vessels become less compliant, less flexible, can get acephalic migraine. So they just get the first bit, episodic neurological deficits, or photopsia. They describe the photopsia as, they're often central and episodic, and they may have scintillations and fortification spectra. Now, they're funny terms. I'd like to define them. Scintilla means to sparkle in Latin, and you can see that is a sparkly effect. This is quite different from a PVD, where it's, right out on the edge of the vision, because people describe this as interfering with their vision of the area they're trying to see. You can't make a meaningful distinction, usually in my experience, between unilateral and bilateral, because don't forget, something that is cranial will be in a hemifield, and patients aren't very good at working out what's in a hemifield as opposed to one eye. Fortification spectra. I always used to think this was due to forts, that they were coloured, yes, that's in the title, but they were due to the ramparts, where it goes up and down on the top. But actually, it's not. It's not like castellation. That's it. Castellation. Where on the tops of turrets. It's not. It's actually derives from old medieval maps where you have these jagged lines, and that's what sufferers describe them as looking like. And of course, another characteristic of migraine is this area of visual disturbance that slowly expands over a period of 5 or 10 minutes. So that's gradually expanding fortification spectrum and scintillation. I shall leave that. So that's flashing lights and floaters. How about asymptomatic retinal lesions? Is this where you should be doing more? Certainly, this is what the founder of the Optomap thinks so. He had a son who went blind from a retinal detachment, and on that basis, has more or less advocated routine peripheral retinal screening. I'm less sure it has an important role now because, whereas once upon a time, if people had referred me up patients with lattice and round holes, we might have done laser treatment for them. We really don't do that now. I mean, this is a Cochrane review of the highest level evidence. And this isn't just some NHS thing. Actually, the author is one of the most eminent vitreoretinal surgeons in the United States. No evidence for prophylactic treatment for a patient like this with either lattice lesions or round hole. So I don't see this as being where we should be focusing. Routine screening of the peripheral retina of asymptomatic patients. So in summary, floaters, exclude inflammation. Is there a PVD? If there's a PVD, check the retinal periphery. You don't need to lie them down. Do it with your 90D or your superfield. And if there's a tear, or a hemorrhage, or a detachment, same-day referral. But if it's syneresis, reassure. And for these very, very, very symptomatic patients, and it is a last resort, but just the patients knowing it's there as a last resort can be helpful. And photopsia, remember that not all photopsia are PVD, and the history will give you the diagnosis. And for asymptomatic retinal lesions, basically no treatment required. And that's just the summary of the referral criteria. Right, I finished slightly early, but I think that's really all I've got to say. Thank you for your attention.
Okay, thank you very much, Paul. Do we have any questions? If again, same applies. If you raise your hand, we'll bring a microphone over to you. Just at the back there, Beth. Thank you.
You just didn't mention tobacco dust.
No, I should have done. I apologise. Yeah, sorry. That somehow got left out. Maybe I deleted a slide or something. Thank you very much for making that point. Yes, if you see tobacco dust, you all know what that is, little bits of pigment. It means it's RPE. It's never a normal finding. You can get it in pseudophakic eyes. Thank you very much for mentioning that. I should have put it in. I'll put it.
So I've always thought tobacco dust, whether you see anything else at all, they're off.
Yes.
Yeah.
I think that's a good idea. I mean, I think all I would say is that in pseudophakic eyes, you can get tobacco dust without retinal breaks, because it's not actually, you're seeing pigment from the iris then. But it's not unreasonable, no.
Okay. Just a little, 3 rows further forward in the centre. Thank you.
Hi there. Just to follow up on the tobacco dust, does a lack of tobacco dust mean no tear?
That's there's some slightly conflicting data on that. I mean, one thing, sometimes you look at things and you're not sure if they're tobacco dust or not, in my experience. You can see some little, if you've got really frank brown tobacco dust, that's one thing, but sometimes the RP cells really aren't that pigmented. It can be difficult to work out if the cells you're seeing in the vitreous are a little bit, because there are shades of brown, aren't there? So I think it's an important thing to document, and I think it does protect you, but I don't think, I mean, I've seen people with tears without tobacco dust.
Okay, should we take this question first?
I'm at the sort of age group where the shrinkage of the vitreous has become all too apparent. I have a large floater which just gets in the way when I home in on the patient's macula. So I'm never too sure if it's theirs or mine. And in one eye I've got...
I know the feeling.
in one eye I have cellophane maculopathy, which I take to mean that the vitreous has still remained attached around the macula. I've discussed possible vitreoretinal surgery for that. Is there any significance into how long it's left before it's attacked with surgery? Does it make any difference whether it should have been tackled early, or does the membrane change with time and the surgery become more difficult?
Can I clarify which membrane do you mean? Do you mean your epiretinal membrane or the posterior hyaloid? I mean, are you talking about just having a vitrectomy for floaters, or are you talking about having the...
No, to get the vitreous to finally let go of the macula so that I can recover some of my visual acuity.
80% of eyes with cellophane maculopathy actually have a PVD. So it's likely you do have a PVD if you've got cellophane maculopathy in a floater. I'm getting uncomfortable about having a consultation in front of so many people. This must be the most public... I'm sure I'm infringing all sorts of GMC guidelines. Thankfully, nobody's videoing this, are they?
Okay, there is a question just...
Thank you. Would you exclude all peripheral retinal degenerations, both lattice, snail track, all excluded, no treatment?
Yes.
Okay, Kamlesh?
My question's a bit of self-interest as well. So myopes, do they become, their vitreous degenerate earlier because of mechanical reasons, or is there some chemical reason as well for...
I don't think anyone... I don't know the answer to that question. It's a very good question, but I don't know. I mean, we give patients these explanations. It's like the retinal degenerations. We say, oh, it's wallpaper stretching on a big room, but I don't think I really understand it myself.
Something I get asked quite often, but is when you have tobacco dust, you might get someone who gets retinal detachments twice. So if someone's already got some tobacco dust, is it likely that it'll go away and then they'll get it subsequently?
No, it
Does
stays
ever
for
go away?
years. So you can't, once it's there, it no longer has any diagnostic utility.
Okay, do we have any other questions? Okay, I can't see anybody else with their hands up. So, again, thanks very much to Paul for that talk. I thought the great thing about it was the videos and actually seeing it's a very obviously mobile structure, and to actually see the videos, because you often sort of see these things on a slit lamp, so to actually have that explained was really very valuable. So I'd like you to thank Paul in the usual way. Thank you.